This
Thank you,
conference
Kapil,
will now be recorded.
for providing me this platform to present some of the things on amblyopia in these sessions. So the topic for today that I have decided is amblyopia introduction and concepts. So basically today we'll go with some of the introductory part regarding the amblyopia and some concepts regarding how the treatment is done. And I have planned the next sessions, maybe it will be on next week, regarding the complete management of amblyopia. So today we'll deal on introduction and concepts only. So I hope the sessions will be very helpful for you. So to begin, so first for these presentations, I'd like to acknowledge Dr. Robert Sanet for guiding me regarding the content of the presentations. I'm very obliged to him for guiding me on all these concepts regarding the amblyopia and its management. So these are the objectives of today's presentations. So we'll be discussing about some myths regarding the concepts on amblyopia, some definitions, classical, functional, and behavioral definitions, and what are the visual abilities that are deficient in amblyopia, and optometric evaluations, and key concept in the treatment of amblyopia. And the more detailed management part will be done on the next sessions. So let's begin. So to begin with some myths, there is a myth that amblyopia is caused by an eye that is not well functioning or lazy. Sometimes, as we all know, the amblyopia is also known as the lazy eye, but actually the statement is false. The reason is that in amblyopia there is nothing wrong with the eye, and the eye is not lazy actually. And in an amblyopic eye, how this can be justified is that in an amblyopic eye, the retina and photoreceptors functions normally, and so the amblyopia is not a problem of the eyes. The eye is not lazy, but the problem is actually in the brain. So this is one myth regarding the amblyopia. And second, early patching is a logical treatment. So is it true or false? To discuss that, it can be true also and it can be false also. The true and false regarding this statement depends upon the goal of the treatment. Early patching certainly reduces the probability that amblyopia will develop, but also there is a thing that early patching reduces the probability that binocularity is developed. Binocularity will develop, means some of the factors can be treated with early patching, whereas early patching also reduces that probability, because in the patching one eye is covered, so the binocularity can be very difficult to gain. So the next myth is, although amblyopia can be successfully treated at any ages, it is more difficult to treat after the age of 8 or 9. Means we all know that as early interventions as we do in case of amblyopia, a successful treatment can be done. But what about those cases who present late? So what are the options for them? So this, regarding this statement, actually this statement is false. There is no scientific study in either the ophthalmological or the optometric literatures to show that this is true. In fact, there is a very good scientific study to show that this statement is false. Means the amblyopia can be treated at any ages. It is not that the amblyopia can only be treated if they present early, that is before the age of 8 to 9. So, and the next myth is there is a critical period, and after the critical period, visual acuity, binocularity, and stereopsis cannot be restored. The statement is true or false. Regarding this, the statement is true, but we should analyze this statement in a different way. For example, I'll repeat the statement again. There is a critical period, and after the critical period, visual acuity, binocularity, and stereopsis cannot be restored. The statement is true, but there is a definite critical period. There is definitely a critical period, but the actual exact critical period is uh, the exact period is not known for sure. Actually, there is a missing word not, and the exact critical period is not known for sure, and the exact period is just after birth to just before birth. So again, in regard to the previous myths and false, the critical period, there is no such critical period. I'll be discussing the literatures, the coming slides. So there is no such definite critical period that has been defined in the latest literatures. Actually, it has the critical period is between 8 years or 3 years has been defined in the previous, in the old literatures, but the recent literatures says that the actual critical period is not known for sure. The brain develops throughout the life. So the critical period, so there is a critical period, and after the critical period, visual ability, binocularity, and stereopsis cannot be restored. Since there is not a definite critical period, in the amblyopic eye, visual acuity, binocularity, and stereopsis can be restored throughout the life. So I like to present you here some of the literatures. So there is a study published and entitled as Success in Amblyopia as a Function of Age, a literature survey. The conclusion of this study was the success rate for treatment of patients using criteria of 4 or more lines of improvement in visual acuity was that under 7 years of age, the visual acuity improvement in visual acuity was 52.1%, whereas over the age of 7, the improvement in visual acuity was actually more, that is 53.8. And the study showed that there is higher success over the age 7, but the difference was not statistically significant. So we can see that although the amblyopia can be successfully treated, although the child is a little bit old or above the age of 7. So to go further with this, the conclusion of this literatures. So to go further with this conclusion of this literatures, when the adult groups, that is when the groups were broken down, further found more statistically significance, that again the results is again a bit elaborated. The study said that under the 7 years of age, the success rate was 52.1%, and the children or the patients with above the age of 7 years were categorized into 3 groups. 7 to 10 years of age, the highest improvement percentage was found, that is 58.6. And from 11 to 15 years of age, the percentage rate of success was 56.8. And over 16 years of age, the success rate was 41.9%. So the lowest percentage of success was 60 or greater than 60 years of age. Although this is the lowest percentage in comparison to the others group, it is the 42% of the success is a bit significant clinically. So again, another literatures that was published at Optometry and Vision Science (OVS), entitled as Anisometropic Amblyopia. Is the patient ever too old to treat? In this study, they evaluated the treatment of anisometropic amblyopia for older patients ranging from 8 to 49 years of age. And the treatments included optical corrections, occlusion for 2 to 5 hours per day, and an active vision therapy to develop monocular visual acuity and binocular functions. And the results was that patients showed success rate ranging from 75 to 100%. Examples, the study has given some case series. For example, in this particular study, there was a patient JT who was 49 years of age, and the amblyopic eye improved from 20/60 to greater than 20/30. And in this is a case series again. A patient named DD who was 39 years of age. He has a visual acuity of 20/200 in amblyopic eye, and it improved to better than 20/40. So the patient who completed the therapy program 1 year before maintained their gains. So the improvement of visual acuity was maintained for longer period of time. So the study concluded that a sequential treatment plan using lenses, occlusion, and an active vision therapy can yield substantial and long-standing improvement in visual acuity and binocular functions at any ages, because we can see the patient shows success rate from 75 to 100%, which is very good. And there was a next study published as maintenance of improvement gains in refractive errors, a comparison of treatment modalities. So, for example, we have improved visual acuity in the amblyopic subject, and this study compared the different treatment modalities with the improvement gains. And the study was done by Fixerland and Krumholz at Sunny College of Optometry, and the study of maintenance of visual acuity gains 1 to 2 years after treatment was assessed, and patients were divided into the following treatment modalities. One of the treatment methodology was optical corrections, and the next was optical corrections and occlusion, and the third one was optical corrections, occlusion, and vision therapy. So the patients were divided into these three treatment regime, and let's see the results. The results was that in subjects in whom the only optical corrections was done, those subjects maintained 50% maintained visual acuity improvement for the period of 1 to 2 years, and the subjects in whom optical corrections and occlusion was performed, they had 60% of the subjects maintained visual acuity improvement for the period of 1 to 2 years. And again, in third subjects in whom optical corrections, occlusions, and also vision therapy was performed, they maintained 100% of the subjects or the patients maintained visual acuity improvement. And the study also found that patients aged 10 to 14 years of age had the best retention of visual acuity gains. And gains in stereo acuity, which is a function of binocularity, tended to mirror the gains in visual acuity. So the conclusion of the study was maintenance of visual acuity gains were best if VT is an integral part of the treatment plan. So if we integrate a vision therapy as a treatment plan, the visual acuity gains or the improvement in visual acuity would be consistent for more years after the treatment has been stopped. And a strong relationship between stereo acuity gains and maintenance of visual acuity gains was obtained. So we can find very evidence-based literatures regarding a proper treatment, or regarding the critical period, regarding the management of subjects with adult amblyopia, that can so we can successfully also manage the adult amblyopes in contrast to the child with amblyopes also. So coming to with these myths and facts of some myths and facts on amblyopia. So let's come to the definition regarding what is amblyopia. So the main thing in the left side of the slides, we can see that how do you define amblyopia, and the way you think about amblyopia will have profound effect on evaluation and the treatment plan. So this statement is very much important. The knowledge the way we think what is what the amblyopia is, it matters very much while we are managing our patients. So basically there are three definitions on amblyopia. One is classical definitions, and the one there is function, and the third is behavioral. So I'll be dealing with all these three consecutively. So again, I like to highlight that again the statement that I have said. How do you define amblyopia? And the way that you think about amblyopia will have profound effect on evaluation in the treatment plan. So the classical definition, going to classical definition, it is the classical or old definitions is based only on visual acuity. It defines amblyopia as 2, sometimes 3 or 4 or more lines difference in visual acuity in one eye as compared to the other, which is not correctable with spectacle or contact lenses. So this is a classical old definitions of amblyopia. Again, I want to repeat: 2, sometimes 3 or 4 or more lines difference in visual acuity in one eye as compared to the other, which is not correctable with spectacles or contact lens. And less than 20/40, or other way it is defined as less than 20/40, sometimes 20/30 in one eye, which is not correctable with spectacles or contact lens. This is a classical definitions or old definitions of amblyopia. So I think most of us don't know when this definitions was given. Actually, this definitions was given in 1713. This was the time when first clinical definitions of was given. I like to repeat that definitions again: 2 or more lines difference in visual acuity in one eye as compared to the other, which is not correctable with spectacles or contact lens. So the definition was given in 1713, and the occlusion was used for the treatment of amblyopia in 1720. The first treatment, there is a recorded, there is an article showing these all historical part. The first treatment with occlusions was done in 1720, and now we are in 2020. For all ophthalmologists and for most of the optometrists, nothing has changed in their definitions. And sadly also the treatment of amblyopia occlusions only for almost about 300 years. So there is a lot of thing, the conceptual thing that has changed from the first clinical definitions to this year regarding amblyopia. So let's go. What are the things that has changed and what is the current understanding regarding amblyopia? So again, I want to repeat our understanding regarding amblyopia. It matters on how we treat the patients. So let's explore what are the things that has been done. What is the current concepts regarding amblyopia? So the next definitions is a functional definitions. These functional definitions was given by Kufridia in 1991. I guess he's an optometrist, Dr. Kenneth Kufridia. He's actually a designer, inventor of BTS system. So the functional definitions defines amblyopia as, and this definitions was first noted in his books Amblyopia, as we can see in the picture. So what does the functional definition says is, functional amblyopia is a unilateral or frequently a bilateral condition in which the best corrected visual acuity is poorer than 20/20 in the absence of any obvious structural or pathologic anomalies, but with one or more of the following conditions occurring before the age of 6 years. So again, I like to repeat the definitions. Functional amblyopia is a unilateral or frequently bilateral conditions in which the best corrected visual acuity is poorer than 20/20 in the absence of any obvious structural or pathological anomalies, but with one or more of the following conditions occurring before the age of 6 years. So what are the 5 conditions that occurs before the age of 6 years that may result in amblyopia? The first one is significant anisometropia. The second one is constant unilateral esotropia or exotropia. The third one is Uh, the third one is significant unilateral or bilateral astigmatism and the image degradations. The third one is significant isometropia, because there is a mistake. So because the definitions defines amblyopia as a unilateral or frequently a bilateral condition. So the 5 conditions that may result in amblyopia are significant anisometropia, constant unilateral esotropia or exotropia, significant anisometropia, and significant unilateral or bilateral astigmatism and image degradation. So let's explore the functional definition. So classical versus new definitions, that is functional definitions. Whenever a visual acuity is less than 20/20, it should be considered clinically significant. So we should not neglect the conditions, especially in the child, where the visual acuity is less than 20/20 and it requires further investigations. If one of the 5 above mentioned that I mentioned in the previous slide is not present, then the possibility of organic changes or conditions must be considered and should be investigated. So the new definitions defines, it's not that there should be 2 or 3 lines and difference between the visual acuity in the 2 eyes. If the visual acuity is less than 20/20, it is a clinically significant conditions and requires further investigations. So as I discussed in a brief, that functional definitions defines amblyopia if the following 5 conditions occurs in child less than 6 years. So because of these 5 factors, different definitions or the different categories of amblyopia has been invented actually. The first one was significant anisometropia, and the definitions, a new term, that is refractive amblyopia, especially anisometropic amblyopia, has been defined. So what is refractive amblyopia? Refractive anisometropic amblyopia. So it is an unequal refractive states between the 2 eyes. Amblyopia in this case is caused by difference in clarity, size, and binocular competitions. And the patients most frequently have a central fixation, but unsteady central fixation. And myopic anisometropia is more common in populations, but amblyopia is much more prevalent in hyperopic anisometropia. And suppression is in this type of subtype of amblyopia is usually less deep than in strabismic amblyopia. And this refractive anisometropic amblyopia may also be found in combination with strabismic amblyopia. So these are the clinical features or characteristics in patients with refractive anisometropic amblyopia. So the next one is refractive isometropic amblyopia. So it is in these conditions a bilateral amblyopia is found in association with relatively high but approximately equal refractive error. Again, refractive isometropic amblyopia. In these cases, a bilateral amblyopia is found in association with relatively high but approximately equal refractive errors. And in these cases also, a central fixation, usually unsteady fixation, is present. And in this subcategory of amblyopia, corrective lenses do improve visual acuity beyond the uncorrected level, but not to 6/6. And visual acuity may continue to improve after the lenses are worn for a period of time, but almost always benefit more with the vision therapy. And this refractive isometropic amblyopia is most frequently in bilateral high hyperopia. If the patient has a refractive error of greater than 5 to 6 diopter or a high astigmatism greater than 3 diopter. So the next conditions, the first one was refractive anisometropic amblyopia features, and the features of refractive isometropic amblyopia is this. Again, to repeat, in this subcategory, the corrective lenses to improve the visual acuity, but beyond the uncorrected level. For example, the patient has visual acuity of 6/36, but can have some improvement with the corrective lenses, but not to the final level. So the third subcategory of amblyopia, according to the functional definitions and the 5 characteristics features, is strabismic amblyopia. And what are the? Let's go with the characteristics of the strabismic amblyopia. And it is associated with early onset, constant, and unilateral deviations. And in these cases, as the one point to know that in a sub category or sub classifications in refractive anisometropic amblyopia and refractive isometropic amblyopia, basically a central unsteady fixation is present. But in strabismic amblyopia, generally eccentric fixation is frequently present in unilateral strabismic. But if the patient has alternate strabismus, central fixation is frequently found in alternate ones, and in the unilateral strabismic, eccentric fixation is found. And when central fixation is found in unilateral strabismic, it can be interpreted as being a function of more recent, not infantile onset of strabismus. Again to go. So when in this strabismic amblyopia case, so when we do a visuoscopy and see the fixation status of the patient. If the patient had a eccentric fixation, then we can know that the strabismus is a long onset. And if the on doing visuoscopy and checking the fixation status, if the patient has a central fixation, then we can know that this is a recent onset type of strabismus. So the next features or next factors was image degradations. So in this subcategory, or it is also known as form deprivations amblyopia, in this case, in this subcategory, the amblyopia is secondary to an obstruction along the line of sight, which prevents the image formation, forming a well-focused high contrast image on the retina. And in these, because of these factors, a well-focused high contrast image on the retina is not formed, and it may be unilateral or bilateral. And the most common causes are congenital cataract, corneal opacities, ptosis, or in cases with anisometropic amblyopia in whom a early total occlusions has been performed. So this leads to deprivation in forming well-focused and high contrast image on the retina and can lead to amblyopia. So let's go to the etiology. So what is the etiology of functional amblyopia? And the minor etiology in all these, because of all these factors, what results or what causes amblyopia to occur is that the minor etiology is a blur. Actually, in image degradations also in isometropics, the minor etiology or one of the etiology is a blurred retinal image, and also a difference in image size, especially in the anisometropic cases. But what is the major etiology is, the major etiology of functional amblyopia is abnormal binocular interactions. That is, active cortical suppressions is developed as a protective mechanism. So this is a major etiology regarding the cause of functional amblyopia. It is an abnormal binocular interactions. That is an active cortical suppressions. But actually, a suppression is a protective mechanism, and retinal receptor processes in the amblyopic eye are essentially normal. So I guess in the first minutes we discussed that the amblyopia is not a lazy eye. Actually, it is a problems or the issues with the brain. And the effects on developing visual nervous systems are cortical and not ocular. Means the retinal receptors or the functional functions of the retina is all okay in functional amblyopia, and the cortical system or the cortical processing is defective. Again, to highlight, the major etiology is the abnormal binocular interactions, and the minor one is a blur or difference in retinal image size, and that creates creates abnormal binocular interactions in the cortex, in the brain. So thought definitions, as I just want to highlight something. The first one was classical definitions that only defined amblyopia on the basis of visual acuity. And the second definitions was functional definitions given by Cofredia, and it took consideration into different 5 factors that can cause amblyopia and subcategorize the amblyopia into different types: strabismic amblyopia, anisometropic amblyopia, isometropic amblyopia, form deprivations amblyopia. and a mixture of strabismic and anisometropic amblyopia. So now the behavioral definitions. So behavioral definitions of amblyopia is a neurological definitions instead of one that is only ocular. Again, it highlights the importance of brain in causing the amblyopia. And the problem is this definitions, behavioral definitions defines amblyopia as the problem of problem is the primarily of the binocular competitions. So as we can see the pictures, only ocular parts considers only the eyes, whereas the behavioral parts considers the whole brain. And to understand and treat amblyopia in an effective way, we must understand the neurology of amblyopia. So let's explore what are these behavioral definitions takes into consideration in defining the amblyopia. So as again I told that the amblyopia is the problem is primarily of binocular competitions. So this definitions explores what is a binocular competitions and how it results in amblyopia. So what is binocular competitions? Binocular competition is a normal process with each eye taking turns. Let's we have a pictures. We can see a mother has a two child. Means let's go with the example. Binocular competition is a normal process with each eye taking turns speaking to the mothers. The both child wants to speaks to the mother. But the competitions can become abnormal as one of the eye becomes totally dominant over the other, actively suppressing the other, thus preventing it from speaking to the mother. As we can see in the second pictures, only the one child becomes close to the mother and the next dominating the other child. The dominance and active suppressions increases with time and increases until the eye no longer makes an effort to speak to the mother. And the amblyopic eye don't mean that the next child or the amblyopic eye is the weak. And again, the amblyopia is not is in the brain and not in the eyes. Again, I like to repeat these things again. Binocular competition is a normal process with each eye, because as we all know that there are two eyes. The visual cortex receive information from the two eyes. So if the one of the eyes becomes a dominant or the other eye becomes abnormal because of the different factors, then the dominant eye actively suppresses the others, and the dominance and active suppression increases and increases until the suppressed eye or the weak eye makes no longer any effort to process the informations to see the things. And the amblyopic eye is not, it don't mean that the next eye is child, but it is dominated or by the other eye that it can't makes an effort to process the visual informations or see. This is a behavioral definitions of amblyopia. So again, to explore more into behavioral definitions, amblyopia is a binocular problem and which is manifested monocularly. Actually, it is a binocular conditions which is manifested monocularly, and the reduction of monocular visual acuity is only the symptoms of a true problems. There are many, but it only one of the symptoms of true problem. As I have discussed that binocular competition, the child becomes suppressed by the dominant eye. So it means that it is not an eye with amblyopia. So we should not take amblyopia as a problem of the eye, but we should make an understanding that it is a child with amblyopia. That is, the amblyopia is not a problem with the eye. Actually, it is a problem. We can see issues or we can manifest different signs in the whole child itself. So this is a main concept in behavioral definitions. Amblyopia is not a issues with only the eye, means not the visual acuity. As we all know that as we discussed, the reduction of visual monocular visual acuity is only one of the symptoms of the true problem. So it is a child with amblyopia. This is a main concept of behavioral definitions. So again, we can see in the pictures the reduced visual acuity in the child with amblyopia is only a tip of the iceberg that we can see, but there are many more things inside these child or inside these patients. So what are the, as I talked, the visual acuity is only one of the thing or the tip of the iceberg in amblyopia child. So what are the deficient visual abilities that we frequently found in not eye with amblyopia, in a child with amblyopia? So let's explore. Again, amblyopia is not just a problem with reduced visual acuity. Deficient visual acuities is usually found in amblyopia patients, in the amblyopic and possibly in the non-amblyopic eye also. These deficient visual acuities is frequently found in, is usually found in amblyopic patients, but these deficient visual abilities can be present in normal eye also. So let's see what are the different visual abilities that are deficient or that are not properly functional in the child with amblyopia. So one is deficient eye movement or fixation skills, unsteady and eccentric fixation, increased saccadic latency, and reaction time for eye-hand coordination. So we just can see the deficient visual acuity is eye-hand coordination also, and in eye-hand coordinations, eye as well as the reactions of our body to a particular stimulus also involved. So the amblyopia is not a issues with the eye only. It is a child or the child will have issues, and the decreased pursuit accuracy, the deficient accommodative skills, decreased amplitude, accuracy, and sustaining ability of the accommodations, increased accommodative latency, poor form discriminations due to decreased contrast sensitivity in these patients, and spatial uncertainty. The child is not able to discriminate laterality, sometimes laterality, directionality, and increased counter interaction, crowding phenomena, and a reduced visual information processing speed and ability. So these are the major deficient visual abilities in the child with amblyopia. So during our evaluations, I'll just in the upcoming slide, we have to check out what are the deficient abilities or efficiency skills that are present in the child with amblyopia, and we have to treat that deficient visual abilities that will successfully lead to proper treatment of amblyopic child. So coming to evaluations, so with discussing these deficient visual acuity in an amblyopic child, let's go with the evaluations part. So there are 4 possibilities for the loss in amblyopes, and the goal in our evaluation of a child with amblyopia, we don't know that the child with is amblyopes or not. We have to evaluate them. The goal is to try to find out which it is the 4 losses. The 4 losses could be the organic change present without amblyopic factors. Therefore, none of the vision is a functional vision loss is a functional nature. Organic changes present and amblyopic causes also present. Therefore, the functional amblyopia is superimposed on the organic amblyopia. And the third possibilities of loss in child is amblyopic factors present without any visible organic changes. Therefore, it is purely a functional amblyopia, and neither obvious organic or amblyopic factors are apparent. Therefore, one needs further testing or post-orbital organic causes. So if a child has a decreased visual acuity, so there are 4 possibilities of the losses. One, if the organic changes without any amblyopic factors, that this means any issues with the photoreceptors, any issues with the optic nerve, any issues with the visual cortex, and any post optic nerve issues, and any media opacities, any corneal opacities. So the organic changes, and the second possibility is organic changes are also present, and also the amblyopic causes is present. The functional amblyopics can be superimposed with the organic one, and the third one is amblyopic factors present without any visible organic changes, and this is categorized purely of functional amblyopics, and neither obvious organic or amblyopic factors are present. Therefore, one needs further testing to rule out any other organic causes for amblyopia. So when evaluating a patient's first a case history or proper case history, there are various, before doing history examinations also, if you have been referred or you see the child with amblyopes, there are different questionnaire available. Adult strabismus amblyopia questionnaire and a child strabismus amblyopia questionnaire are available that you can give to the patients, or the patient, if a patient is a child, you can give. And there are different factor that there are different questions in these questionnaires. We can find that these questionnaires in internet also. So after if available if feasible, we can do amblyopia questionnaire to rule out what are the factors that is there with this child. And again, in a history, key questions like chief complaint, signs and symptoms. If not only strabismus, mainly the parents come with the complaints of child having strabismus, and the amblyopia is diagnosed, and we have to question the parents regarding other issues also. Is at which amblyopia was discovered, what was the first symptoms discovered, is the eye turn, if there is strabismus, and is it when since when it is present, any previous treatment, family, visual history. All these things should be noted in the case history. And after that, there are different tests. I just don't list. I haven't listed all the tests. As I discussed, there are different visual abilities deficient, and on the basis of that, we have to complete test all the deficient visual skills. What are the visual skills that are deficient? We should go on checking with all those abilities. But I just mentioned some general test. I have mentioned some general tests that is usually performed, that should be performed, and that these tests should not be missed in these patients. One is the visual acuity, of course. A visual acuity, after going through questionnaire and the history part, visual acuity, distance as well as near. Mainly, we only check the distance of visual acuity in blind subjects. We also need to check a near visual acuity, and the visual acuity should be tested in a multiple optotype or a single optotype, and a Bruckner test to rule out any strabismus. And the third thing that we should do is oculomotor status. We should check the fixation stability of the patients. We should check the oculomotor functions like saccades and pursuits. There is a test called ANSUCO. Actually, I haven't listed the test. The ANSUCO test can be done easily in these subjects to rule out any deficient in oculomotor status of the patients. And the second thing, after testing visual acuity, Bruckner test, and these oculomotor function test, we should go with checking the fixation status of the patients. So a visuoscopy can be performed either or Heine or Welch-Allyn retinoscope. We can check a visual acuity and determine. There are basically 4 types of fixation pattern that is usually seen in these kind of subjects. The first one is steady central fixation that is found in normal subjects, and the second one is unsteady central fixation that is usually found in anisometropic amblyopes or the isometropic amblyopes, and the third one is unsteady eccentric fixation, and the fourth one is steady eccentric fixation. So if the child has, or if the amblyopia, if the child, the fixation status is on steady and eccentric, it is very difficult to, it takes a lot of time to improvise all the fixation status. But if the eccentric fixation is not present and the fixation status is either unsteady or steady eccentric, then less or less treatment time is required for the child. And visuoscopy, and also we can, if we have the instruments, then we can also check the fixation status through the Hedinger process. And after checking going with the visual acuity assessment, oculomotor function test, and then the fixation status, we should go with checking the binocularity or the binocular status of the patients. Either the 3 main basic test that we should perform is a cover test, unilateral alternate, to determine whether the patients really have a tropia or not, whether the child has binocularity or not. And the second one is Watford dot test to determine the depth and amount of separations. It should be done in distance, intermediate, also the near, intermediate, and distance, three major distances, and also in bright and dim conditions to determine the depth of scotoma. When we perform a Worthford dot test in three distance, that is near, intermediate, and distance, it gives an idea about the size of suppression scotoma in these amblyopic subjects. And when performing a Worthford dot test in light and ambient illuminations or dim illuminations, it gives an idea about a depth of suppressions. For example, if the patient is a strabismic amblyops, then the suppression will be very deep, and in subjects with isometropic or anisometropic amblyops, the suppression will be superficial. It gives us idea about what are the treatment modalities that we should go with on these patients. There are different treatment modalities for the child with deep suppressions, and the different treatment modalities for the child with superficial suppressions. And the third test of binocularity is stereopsis. Either we can use a rendered stereo test or a vectographic plates. So after evaluating, coming to treatment part. So I'll just deal with amblyopia without strabismus, the anisometropic amblyops or the isometropic amblyops. So there are actually two different approaches. Common ophthalmological approach is to make a full optical prescriptions in child with amblyopia without strabismus and go for a total occlusions. And the optometry approach is to go with the lenses, no occlusion or only a partial occlusion, and a vision therapy. So there are basically two approaches that we do. I just want to deal with these two things. The first classical treatment approach is a full optical corrections and a total occlusion of the patient, especially anisometropic amblyops. We can see very much publicity regarding the patients is very happy with the occlusion part with these pictures in first pictures, but actually the reality is different. We can see in the second pictures. So how difficult is it to maintain a patching or occlusion therapy to the child? It is very difficult for a proper maintenance of these total occlusions in the child with amblyops. So there are some points I want to highlight regarding occlusion part. Occlusion, you really want to go forward. So the thing is that, so what are the effects or what are the aspects that we should consider when before initiating a child with full or total occlusions, that is greater than 8 to 10 hours a day or a full day patching or occlusions. The full time patching actually reduces performance of the child in life and the ability to learn, because he has to do all his daily lives or daily activities through the worst eye or the eye with reduced visual acuity. So the performance and ability to learn will be very much problematic if we do a full-time patching in these patients. And also because we are constantly depriving that amblyopic eye from retinal processing, the full-time patching eliminates the possibility of developing a binocularity. And also the full-time patching reduces the child's field of vision, because the child will have can only see with the one eye, the field of vision will be decreased. And also the full-time occlusion can make a cosmetic appearance of the eyes appears worse after the patch is removed. And the full-time patching can result in double vision, and it can also damage the child's confidence and self-image. And it is very much difficult to maintain for both parent and a child. And it is concluded that patching alone has a poor success, and it just doesn't work well. So on seeing all these aspects regarding the reduction in performance of a child, the possibility of eliminating the possibility of developing amblyopia, cosmetic appearance, and then reducing the child's confidence and the self-image, and proper difficulty in maintaining for the full-time patching for both parents and a child. The actually these the full-time occlusion treatment has been uh, eliminated or has been substituted, let's say substituted, or the new approaches has been developed regarding how the patching will be used in these kind of subjects, in the subjects with amblyopia. And there are also some research evidence. The first one that I want to share with you is the article published as Parental Understanding and Psychosocial Impact of Occlusion Therapy on Amblyopic Children and Their Parents. And this study was done at Institute of Medicine itself, and the parents' response in this study, the parents' response as to why patching is difficult. And the a questionnaire was given to the patient's parent party regarding what are the to understand the impact of occlusion and the compliance thing, and the parent responded were like this: confusion on the part of parent as to need for the patching. So the parent party were confused in most of the times why this patching was required for their children, and confusion on the part of parents as to the proper schedule of patching. The second thing that understand how the occlusion therapy has been understood by the parent. And the third one was children absolutely refusing to wear the patch. This was one of the factors that the non-compliance, the development of non-compliance. And the fourth one was patching interfering with the quality of life of the child, and patching was seen as a social stigma, that is both by parent and the child. So these were the factors most frequently found. This is how the parent understood, or there is a decrease, the reasons for a decrease in compliance with the occlusion therapy alone. And also in one study done by Dr. Owen Grossbeiner, in a retrospective analysis of 332 children was conducted to assess modalities, outcomes, and hospital cost of children treated for amblyopia with patching in a UK clinic. And the amount in this study, the amount of patching ranged from 1238 hours. That is very much. You can see how much patching was done to 2815 hours of patching. And the conclusion was that although the mean duration of the treatment with occlusion was long, involving many hospital visits, the visual outcome with the patching alone was very variable. So, and the study in this study published, entitled as a new form of rapid binocular plasticity in adult with amblyopia, the result of this study suggested that a current treatment approach of patching the fellow sighted eye that has been in operations for the past 300 years may in fact be strengthening rather than reducing the binocular imbalance that characterize the amblyopia. So the new concept regarding the treatment modalities has been developed, which suggests that basically occlusions of full-time or total occlusions or the occlusion therapy alone decrease strain rather than strengthening the binocularity. It strengthens a binocular imbalance, which is one of the features of amblyopia. So after the discussing something on occlusions, the next classical treatment approach is lens prescriptions also. And in any books we found that the optimum refractive corrections is written. So how that optimum refractive correction is decided is, it is based on maximum. The every author notes that the optimum refractive corrections should be based on maximum plus, or the cycloplegic corrections, or the full corrections of anisometropia or astigmatisms. And the goal of lens prescriptions in classical method is to provide maximum visual acuity initially, but the main thing that should be considered is what seems to be optimum is not what is best. So the weak link in classical treatment, full-time occlusions, and full optical corrections, that completely ignores neuroscience research and treats amblyopia as a monocular problem instead of binocular problem. So the improvement status, so everything is not there is a weak link in all these things. So I just want to discuss also the classical lens treatment highlights that in a case of high anisometropia, full optical corrections is required. But actually what happens is, in case of high anisometropia, full optical corrections may increase suppressions and make the binocular problems worse and prevent a successful treatment from occurring. So there is a term called instellung. It refers to a person's predisposition to solve a given problem in a specific manner, even though better or more appropriate method of solving the problems exist. So we should not so let's be ahead from this classical treatment approach and go into the new approach regarding treatment modalities in child with amblyopia. So let's not make a concept that the eyes or right eye or left eye is amblyopes. Let's consider the thing that a child is amblyopes, and there are different deficient visual abilities that are present in child with amblyopes, and our main concern should be to treat that or to improvise that deficient visual abilities that are present in the child. So what is the key concept in treatment of these amblyopia child? I told that the total occlusions, a classical understanding of lens prescription, that is optimum refractive corrections, don't properly work well. So what are the key concept in treatment? So I just want to highlight, or I just want to go in depth regarding what are the recent concept in treatment of amblyopes. So we are in a era of neuroscience, and there is a quote by Dr. Ramachandran. We are in the era of neuroscience, and every day more applications are being investigated from brain rehabilitations. Neuroplasticity is reality that nobody denies. So in treating amblyopes, we should always work on the brain, not only on the eyes. And the treatment of amblyopes is based on current knowledge in neuroscience and not old outdated ideas and myths regarding the eyes is lazy and other thing. So the key concept is neuroplasticity and neurogenesis exists throughout the life. And as in discussing one of the myths regarding the amblyopia, I discussed that the amblyopes cannot be treated beyond the critical period. But the recent research has shown that the critical period lasts throughout the life. So we can treat amblyopia at any ages. So neuroplasticity, what is neuroplasticity? Neuroplasticity is a process by which neurons can increase their connections with other neurons through sensory stimulations, learning, and experience. So let's explore some more into that. So a research scientific basis of these neuroplasticity or optometric vision training in the child with amblyopia is, there is a book called The Principle of Neuroscience. It is actually considered as the Bible of neuroscience. What does it states that a neuroanatomical and neurophysiological changes are constantly occurring in the brain. Sometimes it is a creation of new synapses, and sometimes it is an increased amount of neurotransmitter stored in the presynaptic button. Sometimes it is a remodeling, either strengthening or weakening or an existing synapse. This is what makes all new learning possible, and the change in the brain is possible regardless of the age. That is not what I am saying, that is what the book says. So the effectiveness of stimulations has been demonstrated and replicated in wide variety of studies. We can find a plenty number of studies. In fact, it is known that regular activity and systematic activities and enriched environment stimulates the growth of new nerve connections, mainly in the hippocampus and throughout the life. This was stated by Greenwald and Gauss in 2002. And more concepts regarding amblyopia is that the cells in the visual cortex, or the cells, neural cells that are that process the informations from the amblyopes have not or are not destroyed. Actually, they are sleeping and they are ready to be awakened. And different researches or different research quotes that asymmetrical visual experiences causes synaptic inhibitions of input from the deprived eye, and that the reduction of such inhibitions restores the binocularity. As during the explanation of definitions, we explored that there is an active suppression mechanism from one eye to the other eye. If that suppression is inhibited, we can stimulate the binocular cells that are present in the visual cortex that are sleeping. And the next research highlights that alleviating neural inhibitions in adulthood with drugs or training paradigms may unmax the full capacity for lifelong trainings. And these things also highlights that the nothing for organic is changes is there in the brain with amblyopia. It's just that the proper connections, the proper processing is not taken because of the active suppressions mechanism that has been undergoing in the brain or the brain of amblyopic brain. So they are just sleeping, and we can stimulate, or from the training or from the, let's say, optometric vision training, we can unmax that suppressions that is happening in the brain and can treat the child with amblyopia successfully. And the sleeping cells, the cells sleeping, they are actually ready to be awakened. And how will they be awakened? So it's a vision care based on a neuroscience. There is a behavioral vision care based on neuroscience. We can find a key to awaken the sleeping cells. So what are the keys? So these are the three big keys to success in awakening the cells or awakening the sleeping cells in amblyopia. The first one is not the classical approach of lens prescriptions, but the behavioral approach of lens prescriptions, and not the total occlusions or behavioral use of occlusions, and an optometric vision therapy. The three categories, that is monocular therapies that works on improving the deficient visual skills, monocular fixation in a binocular field, and the different binocular vision therapy procedures. These are the basic three keys to succeed in a child with amblyopes. So these three keys to success regarding how the management approach should be there in the patients with functional amblyopia, I'll be discussing on next sessions, maybe next Friday. So detailed management will be on the next series. So any queries, I'll be happy to answer. Thank you.
Okay, thank you so much, HIRA sir. So, so can we start with the what others clinicians practice to treat the amblyopia therapy? I want to take some review from the audience. So, anybody want to share experience about amblyopia? Please come with the questions. You can unmute yourself and go for the question.
Actually, I just wanted to highlight again our yeah, it's okay. Our understanding on what is amblyopia, it matters very much regarding how we approach a patient with amblyopia. So yeah, any audience want to share anything, they are kindly welcomed.
Hi, HIRA.
Yeah, Asik sir. Good afternoon, sir.
Well, it's good evening here.
Yes, sir. Good evening.
All right. So that was a wonderful presentation, but you gave a descriptive insight to the approach and management of amblyopia. However, I had a couple of questions and I have a couple of suggestions to make. Since we consider nowadays, like amblyopia as a problem with resolution, recognition, brightness perception, and loss of contrast. So, would it not be good to explore something about the non-invasive test, such as pupil testing and electrophysiological test in amblyopia? Like it would have been better if you could have added a few points on that section.
Yeah. Yes, sir.
Like especially the studies have shown, the recent studies have shown that there is problem in the multifocal ERG response in the central 10-degree region in the amblyopic eyes as compared to the non-amblyopic eyes, as well as there are, there is a reduction of the amplitude, the ERG amplitude in pattern ERG response, which specifically test the ganglion cell response in the general eyes, right? So, if we could have added up a few things about electrophysiological testing, and it would have been much better. And the other thing is also about testing, pupil testing. Like pupil testing nowadays, it is considered to be a gold standard, non-invasive procedure, which you can actually elicit in any form of clinical setting. So what you it is seen that the constriction velocity of the pupil and the maximum pupil constriction amplitude, it gets severely depressed in amblyopic eyes as compared to the normal eyes.
Yeah, so I just highlighted some descriptive theme. In the next sessions, maybe I will highlight something on syntonics. There is something called syntonics. There is one subspecialty that the syntonics is also one of the modalities of treatment in these amblyopic subjects that takes into consideration the pupillary thing that you have explained.
Okay, right. That would be great in next session then. So the other thing is like you've been stressfully mentioning that amblyopia and the word child. So is it something that like you are trying to address specifically the amblyopia occurs only in child, or like nowadays we don't say that
Portion actually the term that I want to highlight is the eye is not amblyopic, but the whole body or the person is amblyopic. That is what I want to address. It's not that
because
the child,
we don't say,
the whole person.
Because nowadays we don't stress upon the term called plasticity, because there is nothing called plasticity. It's all about awakening the visual cells in the brain or in the eye or wherever.
Cells.
The sleeping cells or the sleeping neural connections, whatever it is.
Yes.
Right. And the other thing is, are you going to talk about, maybe in the next session, more about the optimal corrections, like, the optimal correction measures that would be more interesting in terms of dispensing as well? Maybe a bit more on that. The form, the type of lens, especially, or maybe some form of other form of corrective measures such as contact lenses, or even refractive surgery.
Maybe we'll. Yes, sir. You can go ahead.
Yeah. So the other thing is, like, even in my clinical experience, I have seen a couple of people with very high prescriptions who have underwent refractive surgery happen to gain few more lines as compared to best corrected visual acuity with glasses or even contact lenses. So like
maybe I'll
sorry,
I'll discuss these. So these I'll discuss these. What are the unlike the classical lens prescriptions? What are the decision, or what are the things that should be taken into considerations before prescribing or first considering lens prescriptions? Maybe I'll go with these things in the next sessions, and we can have discussion in the next session, sir. I'll be happy to take you these things in the next session, sir.
Sure. Fantastic. Congratulations. Good.
Yeah, sir. Thank you so much.
Thank you.
Thank you, Asik, sir. We are so happy to see you in our platform. So if anybody have a question, please chat on the box, or you can unmute yourself and come with the question. We'll be happy to see you.
Yeah, I can say one question, Kapil, there. A question from Solu Gautam. What is the difference between critical and sensitive period? Yeah, I don't know from what aspect. I think there are different aspects how these questions can be answered. A critical period means how all the development, the neural development, all these developments happens in the child. A definite critical period of 3 years is considered, uh, and sensitive period. I don't know that. I think I need to explore that the term sensitive period in these subjects. Maybe the sensitive period means how much sensitive the child or the person can be. Maybe it is reflecting that period. Maybe I would answer these questions in the next sessions. Maybe the sensitive period.
Yeah, sir, that's good. Okay, I want to see there's some question, but don't worry. I don't know. If anybody have a question, please pop on there. We will be discuss, and if you have any ideas you want to share, please unmute yourself and make the question.
So yeah, in the next the thing to add in the next sessions, I'll just highlight some things on the lens prescriptions considerations, the considerations and occlusions, and what are the different modalities of vision rehabilitations that can be done in persons with amblyopia. Maybe we'll discuss that sessions. Today's sessions was a more descriptive regarding how the concept has arrived, the current understanding on amblyopia has arrived from the classical concept to the recent concept in amblyopia. So maybe we could get a lots of questions or lots of queries in the next sessions, Kapil.
Okay, okay, sir. Sir, I have one query here. So, what in general practice we used to only treat the myopia patient up to the 14 years of age, and we just always neglecting this thing. But recently, research and other things are more compelling that we have to treat after the 14 years. So I found there is always contradictory. There is always been debate between two these schools of thought. To overcome with we have to treat after the 13. So what are the what are the most cardinal things that we should have to consider? Yes, we have to treat after the 14 years as well.
No, actually, during the discussion of myths, there is no such. The recent things has highlighted that there is not a thing called critical period that lasts up to 6 to 7 years, 7 to 8 years of age. So that apart from that, we could not treat. And also, we can find plenty of literatures. I'll say many literatures that highlights or that highlights how the regarding the successfulness or successful treatment of adult anisometropic or isometropic amblyopia. The main thing is the basic approach is that the lens prescriptions, and the main thing is evaluations and finding out what are the deficient visual abilities that are present in a person with amblyopes, and working on that and rehabilitating that kind of deficient visual abilities, and then we can treat the patients or adult patients. And the one difference I just want to highlight, the one difference in treating a child and the adult is that the child's brain is very much flexible. So the improvement in the deficient in visual ability, the skills that are deficient can be treated in very less time in the child, uh, in contrast to this in older adults, because the brain develops very slow in especially the adults. The treatment time in adults is different, a bit longer, I'd say a bit different in comparison to the child.
That's great. So there is another question from the Nikita Nirola. Thank you so much for your question, Nikita ji. And how do you treat a child 1 to 2 years with IX?
Actually, if a child, the best thing that we should approach is, actually we can't, in a 1 to 2 years of a child with intermittent exotropia, we can't work out with the eyes itself. So there is something called motor therapy that we can perform. So the motor therapy is that our visual connections is with the ear also. So in the ear there are two things. One is otolith and the next one is semicircular canals. That otolith, the two things, otolith and semicircular canals. Otolith results in the linear accelerations, or the when we linearly accelerate the uh, uh, when we swing, when we hop, and when we jump on a trampoline, our otolith is stimulated. Whereas when we do a rotational activities like rotating in a chair, then the semicircular canals is activated, and there is a understanding that in a child who has outward deviations, a linear acceleration will help them a lot. So regarding that questions, how do you treat a child 1 to 2 years with intermittent exotropia? So linear accelerations, maybe we can make a patients, ask the parents to make a jump or off with the child, or you can make a child jump in a mini trampoline. So these, or you can just play with a child or swinging activities for about 10 to 20 minutes per day for some period of time. Maybe I'll personally take the duration as 6 weeks. So these kind of motor therapy will help a very lot in improving the status of this child. So the next question, I hope that answers the questions. And after that,
Yes, sir.
if the child, if the eyes, I just want to highlight one more thing. If the child has significant refractive error, then a child with 1 to 2 years, if it is associated with hyperopia or any other thing, we should evaluate the patients and make prescriptions decisions. Before initiating any prescriptions, we can do these kind of therapies in this child and work. I hope the intermittent exotropia will go on decreasing, and after that we can make visual interventions in these, like the prescriptions of binasal occlusions and other thing.
Okay, okay, sir. Sir, there is another question from the Chandan sir. So he is asking her, is there any other method to calculate the angle of separation apart from the Woodford dot test?
Regarding that questions, the Woodford dot test is so very much easy. The test to do. Why to explore other things to calculate the angle of separations? We can go with checking the separations or the from in different distances with the help of Woodford dot test. I hope that is if you want to calculate, there will I just want to say that is there won't be, I think, any conditions in which you won't be available with the Woodford dot test, and will be available with different sophisticated techniques. So apart from, I guess in my understanding, apart from WFDT, if you want to calculate the angle of separations, you can do a field chart in Syntonics, but that will be a more sophisticated thing to do. So I suggest Chandan to calculate that angle of separation from Woodford dot test itself. So if you want to go with another thing, there is something called field chart in Syntonics, and you can go with that field chart if you have.
Hira, I think there is something called microperimetry.
Yeah, sir. Also, there is something called microperimetry. Yeah. But I thought that would be out of scenario thing, and
So, okay, I guess we have almost answered the many of the queries. Okay, let me check if there are any question or not. I guess,
Hello.
Hira sir, we answer. Yes, yes, please.
I have a question for Hira sir.
Yes.
Sir, so I have seen lots of adults with amblyopia, and it's already they have been in such situation that they have been told by doctor that doctor optometrist they like the treatment of adult amblyopia is not possible. So in such
Yes.
condition, they are staying back. So what will be your suggestion? So how we can proceed further in order to be touched with them that adult amblyopia treatment is still possible?
Yeah, very much important questions. The one thing I like to highlight here is we can very much motivate or encourage a patient parent. If a child is amblyops, we can very much easily motivate or encourage the patients that the findings in the child is this, and it will have very much problem in overall development of the child. The visual development will not be proper, and also the these conditions of the child will have effect on his learning activities and also the academic activities. And but in contrast to the adults, the main thing I see is a motivation, and also if you have a proper time to counsel with the patients, I see the main thing is counseling and making understand what actually is the conditions with the patients. And also I see is the compliance of these amblyopia treatment is very good with the in the child, but the adults frequently neglect these conditions. To overcome this, and the as all the visual functions or all the visual abilities has been already developed, and the deficient visual abilities is there. The main thing again to highlight is the counseling regarding how the patient has the understanding of what kind of conditions does he or she have. And also the main thing, the barrier I see is the treatment time. Again, to highlight the treatment time, and the treatment time is a bit longer in adult in comparison to the child. So it matters what is the priority of the patients. So we don't can compensate, or we can't force the patient to be enrolled. But what we can do is to see what is the understanding, or to compare what is the understanding of the patients regarding amblyopia, and make them understand if they are right or wrong, to keep them on proper understanding on what the amblyopia really is and what are the different effects it will have on his or her overall performance of the patients. And then we can enroll or counsel them accordingly to that. For example, I just want to share one or two patients. He was actually a simple labor doing persons, and suddenly noticed that he had a deficient vision in his one eye. But it's not that he has to do a lots of near activities or lots of issues with the lots of works with the near activities or fine skills or fine things is not required for him. So in that case, we should just make, or the first thing that we can do is make or modify optical prescriptions or the lens prescriptions depending on his conditions, and explain what the conditions is. If we don't feel that the thing that we are saying is required for his daily life and in his further life, then he will not be enrolled. And another case scenario is uh, IT workers or the office, those persons who just has to do lots of activities on the computer screen, and he becomes very much symptomatic by using his only one eye. And if that persons come to you in these conditions, it will be very much easy to counsel the patients regarding what are the what is the conditions that is causing symptoms in these patients, and we can successfully treat. And the final thing that I want to go is it depends upon individual to individual and the necessity of the patients. Those patients who has lots of near walks or very much fine eye has to work for especially the near walk, then he might we can possibly make him enrolled into all these treatment modalities. But if the persons don't need it, then we cannot force him to be enrolled. The main thing to conclude is to go with the proper, to make a properly understand what is really a condition is with your current concepts of understanding in amblyopia. I hope that answers your question.
Yeah, I got it. Thank you, sir.
Okay, it's been amazing session. So I guess we have answered the many of the queries, sir. Let's check if there is any question remaining or not. Okay, here, sir, we are about the end of the session. So if you have any good notes to our platform, or if you want to give any suggestion to more
again
session, yeah.
Yeah, because I see all of us are the practicing optometrist or the eye care practitioners. Our understanding of amblyopia matters very much in how to treat the patient. So let us make a concrete concepts of what the amblyopia is, and make a treatment or establish a proper treatment modalities in these patients.
Okay, that's good. Okay. So if anybody like who are just recently graduate or who are practicing on the periphery or in the clinic, what should the most considering thing that we should have to convey for the patient that we are completely treating with the amblyopia?
Yeah, actually we can show that what are actually the main thing lies in the evaluation part, Kapil, I see. Because in amblyopic children, we just only check the visual acuity and say that the visual acuity is very poor. But if we give a time and go on testing all the visual abilities of the patients that I have mentioned that are usually deficient in a person with amblyopia, we can make a person motivated in enrolling into the proper treatment modalities. Actually, it's not about the visual acuity itself. There are many more deficient things that are present in the person with amblyopia, and we can highlight on these issues, and we can go on proper treatment modalities. So what are the treatment modalities? Maybe we'll discuss in that on the next sessions.
Okay, sir. Okay, sir. We also used to say that the amblyoptic therapy is a holistic approach that the clinician also have to treat them very willly, and their parents, and from their schools, from their teachers, and from the friends, and even from the ophthalmology. Is a point of from the being as an optometrist. If you have to see the I guess I would say other parameters like other people's what are the what they are thinking about the treating of the amblyopia. If you have to see from the optometrist to the all these circles, how much we are satisfied. Yes, they are doing that's a very good job. Or what is your response? Like what is your
actually what I see is the current scenario. I see the contemporary issues is that the main thing is that the most of the hours of the children is spent, or they spend most of the time with their teachers, especially in the schools, 7 to 8 hours a day with the teachers. So the main thing is that we should make maybe we can do it in the individual level. The concepts regarding the problem that the child is having is not taken into considerations by most of the teachers. So especially I see these things in the in child incorporating with the total occlusion, let's say occlusion. So the thing is not actually satisfactory to say in Nepal. So the awareness regarding the problems that the child could have that especially affects the learning aspect. I would say learning aspect, academic aspect should be aware, especially to the teachers, so that we can have a proper compliance with the treatment of these amblyopes.
Okay, sir, I guess we are at the end of the session. So once again, thank you so much for your wonderful presentation and all the attendees that are separate their napping time and going to our session. It's we are very thankful for all of you. And sir, I guess we have answered many of the queries. So I once again, I would like to before ending the session, I'd like to express my sincere gratitude towards the today presenter, Mr. Hiranath Dahanat Sir, and all the attendees. And also, I would like to appreciate all the helping hands for the today I Talks program. Here with I ending the today's session, requesting all for you, please drop your review and feedback. How could we make this platform more better? So stay safe, stay inside. Thank you so much. Thank you so much, Hira sir. Have a good day.
Yeah. Okay. See you.
But in case if it is early, the